I think we're going to start the session. Good evening, everyone, and good afternoon for people who is out different part of the area. And basically, this session about the refraction session, it will be help me. I'm in trouble. And the first speaker, there's a slight change in the organization of the speakers. So Dr. Sharif Amara, he's consultant in Dubai in the consultant hospital. Eye Consult Hospital. He will talk about management of intracorneal ring complication. Dr. Sharif is
Hi, good evening, everybody. Thank you, Dr. Osama, for the introduction. I just am going to share. Okay. Okay, now you can see it
okay.
right now, right?
You can go ahead.
Okay, so my talk today is the intracorneal ring complications. The mechanism of action of intracorneal rings is the insert in about the depth of 75, at least 75 corneal depth in the peripheral cornea. It separates the corneal lamellae, resulting in shortening in the corneal arc length. So the central cornea flatten and the peripheral cornea become more steep, and so the thicker the insert, the increase in flattening. So the mechanism of action, it reduces the corneal steepening and decrease irregular astigmatism. And it causes displacement of corneal apex to the center of the pupil. The advantage of the intracorneal ring is it's a reversal in action. We can remove it anytime. It's minimally invasive approach. It doesn't affect the center part of the cornea and improve objective visual outcome and restore functional vision. The indication is a clear central cornea. The key reading should be between 45 to 60 diopter. The corneal thickness is at least 450 microns at the incision size, and the patient is contact lens intolerant. The contraindication is the key reading more than 60 diopter. The central corneal scar is not fit for intracorneal ring segment. Recurrent corneal erosion affects the healing of the cornea. Low pachymetry, the percentage of collagen fiber is decreased, so the effect of intracorneal ring segment is less. The most important thing is unrealistic expectation. If the patient is think that he can see 6/6 after the ring insertion, don't do this for him. The most common intracorneal rings you are used Intex, we are using Kera ring or Ferrara ring and Mayo ring, but I think most of us is using the Intex or the Kera and Ferrara ring. We are centering on the ring on the geometric center of the cornea, and the depth of the tunnel should be between 75 to 80% the thickness of the cornea, and the incision was made along the steep axis. I'm using the intralaser platform. I think all of us now, or most of us, is using the femtosecond laser to creating the incision and to create the tunnel. Now I will introduce one. This is my first case. This is a 20 years old female. She has a keratoconus, diagnosed as keratoconus. She's complaining of decreased visual acuity both eyes. The uncorrected vision on the right eye is 0.15, and the other eye, the left eye, is 0.05. And this is her refraction, and the best corrected vision is 0.4 and 0.3. So this is her pentacam. This is the right eye, and this is the left eye, and this is the OBD scan for her. We can see here the corneal. Definitely the left eye is more advanced than the right eye. We can see that the steep K here is 52 and the flat 49. The other eye is 56 and 51. So I decided to make corneal Kera ring for her. This is the plan, and as long as her best corrected vision is less than 0.5, so I decided to make the steep axis on the topographic axis, the incision on the steep topographic axis, which is 102 for the right eye. This is the incision side, and 79 in the left eye. This is the incision side. This is the post-op. This is the right eye, and this is the left eye. This is the same as our plan. And this is the post-op. This is the difference or comparison between the pre-op autoref and the post-op. We can see decrease in both myopia and astigmatism in both eyes, especially for the left eye. And the vision, the uncorrected vision, is improved in the left eye from 0.05 to 0.2, and the best corrected from 0.3 to 0.4. And this is a great result for me. But the patient is complaining about the quality of vision on the left eye. So I did corneal topography for him, OBD scan. I can see very good result. I can see significant flattening of the cornea. I can see displacement of his apex to the center. The ectatic area become less. So I told him everything is going fine, everything is okay. Just it's a matter of time. The vision will improve. And this is the classifier or the navigator, which gives the percentage of the diagnosis according to the shape of the cornea. We can see the preoperative is the diagnosis is keratoconus 99%. Postoperative it's hyperopic refractive correction or others. So this is a good, but the patient is still complaining from his quality of vision in the left eye. And so I decided to go more deep. So this is his wave front error. It's the surprise is that his wave front error is become worse from 1.7 to 2.1, and I can find here that the total coma is almost the double from 2.4 to 4.8. So this is the reason why the patient is not happy or is not satisfied after the corneering. So I went back to his preoperative map. This is the topographic map, and this is his high order aberration. This is the coma aberration. I can see this is the axis of the coma aberration. And so I put my Kera ring. It's not, if I can find my Kera ring is not on the same axis of the coma aberration. So it should be like this. I put it like this, and it should be like this. So this is the one I put, and this is the should. If I want to respect the coma axis, I have to put the Kera ring like this. So this gives us the discussion of which axis I have to follow. The coma axis. We have three axes actually. You have topographic axis, we have refractive axis, we have the coma axis. We all know that the coma aberration is one of the most common aberration in keratoconus patient. Actually, this subject we have a lot of controversy. Till now, nobody can make sure that which one is perfect. So the coma, the topographic, or the refractive axis. Several studies have shown that the high order aberration, especially vertical coma, are highly prevalent in keratoconus, and most effective correction occur when the ring segments are positioned. I decided to change. We should put the incision. If this is the coma aberration, we have to make the incision here instead of the steep axis, and put the ring on the same axis of the coma aberration. So this is why the patient is not happy with the result. So coma has been demonstrated to have a negative effect on visual acuity because of the optical blur. Therefore, decreased coma along with topographic regularization might have contributed to improvement of the corrected distance visual acuity. I have another case. I have this patient in my clinic. He did this Kera ring outside. This is very central Kera ring, very, very central. The patient is complaining a lot of halos and a lot of starring of light, and I can see this is the OBD scan of the patient. This is the pupil, the size of the pupil, and you can see here the shadow of the Kera ring. This is before. This is in photopic vision, and this is with mesopic. This is very strange. We need to respect the pupil size before implanting the ring. We all know that if we need to correct the myopia. If the patient has more myopia, we have to put the Kera ring more central. If he has astigmatism, we can put it 6 millimeter or 7 millimeter, but we have to respect the pupil of the patient. If the pupil of the patient is like this, I cannot use 5 millimeter Kera ring in this patient. So I decided to remove the Kera ring, and definitely I cannot put in 6 millimeter because sometimes there is overflap between the two tunnels. My plan was to put in the 6-7 millimeter and use Intex, but the patient doesn't want to proceed for more again for corneal rings. This is a case 3, and this is very rare and very strange complication for me. This is a patient with keratoconus on the right eye. I put the Intex, and everything went fine. And this is the result. This is the pre-operative and post-operative of the patient. And this is also the pre in the right eye, and this is post. We can see the displacement of the cone into the central part and decreasing in the ectatic area. Patient is complaining of persistent discomfort and pain. I wait for 2 to 3 months, still complaining. He is not complaining from the vision, but the patient is complaining from pain and discomfort. The intact in a good depth, it's not superficial. So I decided to remove the intact, and I find the paper said that sometimes when we insert the intact or the intracorneal rings, sometimes it touches one of the corneal nerves, causing persistent discomfort due to direct contact. And this is one of the very rare complications of the intracorneal ring segment. And so segment migration, also one of the complications. We can treat it with, we can make a suture, and this can happen also if the corneal ring is very close to the site of incision. We have a lot of complications. We have a corneal opacity. This is one of the cases I can see here, the broken intracorneal ring. I'm about to finish. This is one of this is decentered intact due to, I think this is due to manual dissection, and this is also due to manual dissection. Corneal vascularization, one of the most common complications of intracorneal ring. Okay, thank you so much.
Thank you very much, Dr. Sharif. That's very interesting. And I think really femtosecond laser make the rings is much easier, less complications.
Definitely.
But we'll go into Dr. Muhammad Hosni. It's a pleasure to have him with us. He's like, hi, good evening. It's my pleasure. So basically we'll go, Dr. Muhammad Hosni is, or Professor Muhammad Hosni, we're going to talk about management of high astigmatism, post-corneal graft, which is always very challenging topic we're always facing. It's all yours.
Thank you. It was a very, very interesting presentation, Dr. Sharif. فعلا والله. I had some comments, بس يعني later on إن شاء الله بإذن الله.
إن شاء الله. If you save time from your session.
لا والله بجد, it was really a good presentation.
Yeah, it is. That's definitely yes.
Okay. So good afternoon, everyone. It's me again. I really enjoy giving any presentation online when the panelists, most of them are friends, and this is the case now. So hello, everyone. Hello, Dr. Mitra. Hello, Ahmed Alilo. Hello, Sharif Amira. Long time no see. I've just seen you yesterday, Osama, so I can't say this. So
welcome, Dr. Muhammad. It's a pleasure to have you tonight.
Thank you. So my presentation today is a little bit on the funny side. I have been presenting this case in many meetings. I think this is like the 5th time I presented, and it addresses the concept of post-PKP astigmatism, and we all have this problem in our practice, especially doctors who do a lot of penetrating keratoplasties or DALCs for that matters. And when you end up with a chunk of astigmatism, sometimes it's really challenging. Now, femtosecond laser assisted PKs has changed dramatically the amount of astigmatism that our patients end up with. But again, still we do have astigmatism and we need to tackle it. So this is a case that I've tried many things, and hopefully the patient is still as happy as when I finished his workup. And I'm going to discuss it with you guys. These are the references. And post-PKP healing usually ends with corneal astigmatism. After 1 year of surgery, the usual corneal astigmatism is in the neighborhood of 1 to 5 diopters. We all have patients who have like 0.5 diopters of astigmatism or 0.25 diopters of astigmatism. We photograph the autoref and we're very, very happy. But this is out of the norm. This happens every blue moon. Normally, we have like between 1 and 5 diopters of astigmatism. Femtosecond PKP has dramatically reduced the amount of post-operative cylinder due to the innovative wound designs, less suturing, and smoother post-operative course. But when you end up with astigmatism, what can you do? You have many weapons, and in this particular case that I'm presenting today, I use 2 weapons for the same enemy. So which one would I use more, and which one would I use first? And this is really a subject for debate. But again, we don't have much time to stop between slides and take the opinion of the panel and tell them what I did. So I'll just dash off with the presentation itself. So this was a 41-year-old male who underwent femtosecond PKP in December 2014 by myself for advanced keratoconus. Surgery was uneventful with a mushroom design. Everything was absolutely fantastic, smooth recovery, traveled after 2 months on his medications. And then he showed up after 5 months of the surgery with an attack of allograft rejection and a chordaduced line tangential from 12 till 3 to 12, from 12 to 3 o'clock. and accompanying suture-related inflammation, of course, in the same quadrant. Rejection was treated with topical and systemic steroids under a cover of topical moxiflox for antibacterial suture-related infection. The patient responded very, very well, as they always do, and signs of both rejection and infection disappeared. The problem with rejection is the same problem that we face when you have a patient with uveitis. You can treat the bout and everything will be absolutely dandy and fantastic. But again, one time after one time, you will end up with sequelae of this rejection. Usually it's fibrosis in the wound and irregular astigmatism. So the area of treated inflammation showed moderate scarring, and he was followed up regularly every month over the next 6 months with a quiet eye and the best corrected vision of 0.7, which is 6.9. So the refraction was plus 2.75 sphere with a minus 10 sill. The patient was intolerant to hard contact lenses, as most of my patients are. I don't know if your experience is different. And to spectacle correction, of course. So this was an artificial sort of best corrected visual acuity. He saw 0.7 with the correction in the office, in the clinic, but he could never wear the glasses. So he never saw actually 0.7 in his daily activities. In February 2016, he presented to my office seeking a solution, okay? He had an upcoming job interview actually in the Emirates. So this was the pre-treatment oculizer. In these patients, I rely on Placido disc more than tomography. So this was his oculizer. And as you can see, there was a 9 diopter of astigmatism in his topography. Again, 8.5 diopters of astigmatism. So we decided to go for arcuate incisions on the FS200, which is, at the time, it was the only femtosecond laser machine that we have in our center. Now we have 2. So which nomogram? Most astigmatic keratotomy nomograms nowadays are aimed for clear corneal limbo-relaxing incisions, like the Adeno or the Napa. And these are mainly for cataract surgery, not for post-operative and post-femto keratoplasty. So we use the combination of Magee-Buzar, I will come to this later, and another FS machine, which is the interlace nomogram for a 7mm optical zone. We believe that the topo treatment overlay on the FS200 will help us in planning the exact extent. And this is very, very nice. You actually project the topography of the patient on the machine, and then you sort of move your arcuate incisions until they are bang on the area of scarring. And so you get an excellent result without typing in just the axis of the centration of your arcuate incision. So for example, if you put the arcuate incision at 60 degrees, for example, and then you do the overlay of 60 degrees on the topography, sometimes you need it to be 68, 64. So you actually move it, and this is very, very nice. And this is a handy tool when you're using the femtosecond laser. What we really missed at that time was the cyclotorsion management. After docking of the patient, you end up with a little bit of cyclotorsion. And this is a primarily astigmatic correction. So any off-axis treatment will end up with a sub-minimal difference in the achieved treatment that you would like to give the patient. So this was the plan, exactly as you can see. You can actually rotate these arcuate incisions as much as you want. You can go anti-clockwise, you can go clockwise, on site on the overlay that is shown on the panel and on the screen of the machine itself. And we aimed for 70% depth. Why 70% depth? Because I was a little bit scared that I would do a perf in this patient who had a previous PK. And we did an offset. So the plan was to do an intrastromal arcuate incision. And at the time, this was very en vogue. This was very something trending that you do the arcuate incisions with the femto laser intrastromal. So you avoid the any danger of, for example, infection, because you haven't opened the epithelium and you cannot have the stray microbe going inside your incision. And at the time, people said that it gave the same results and gave excellent results. So this is what we did. And this is actually a photo of the patient immediately after the treatment from the monitor of the machine. And it was an intrastromal effect. And we sent the patient downstairs immediately to do a tomography. and a topolizer, and just to get, a placido disc topography as well, to see the effect of the incisions that we've done. And surprisingly, we didn't find that it was very much effective, because the astigmatic correction that we corrected was only, you see, from 8.5, and immediately, and this was, if you go here, it's 434, and this is around 6. So it's like an hour later. This was the topography done before the operation. He went upstairs, changed his clothes, went down to the operating theater. He did the arcuate incisions, and immediately went down to do another tomography, and he ended up with 6.7. So from 8.5 to 6.7, which in my mind wasn't a great deal of success. We only had two diopter of cylinder corrected. What do we do now? Should we open the incisions so maybe we may get more effect, or should we leave it for a few days to reach the maximum relaxing effect and the remodeling of the cornea, then reevaluate? Actually, our options was to proceed and open the incision, or to chill out for a few days. I immediately sent the patient back to the OR, and we opened both incisions to the surface with the good old school to do a good arcuate incisions, and to feel the gaping of the arcuate incisions, and to feel the effect of the arcuate incision. And immediately, from 6.5 diopters, the patient became 5.6 diopters. So we started with 9 point something. With the topography, it was 8.7, and ended up with 5.6 with the arcuate incision. So this is the first message, that you can treat astigmatism with the arcuate incision, with the femto-arcuate incision. I prefer to open the incision up to the very, very surface. And again, you will not end up with a maximum effect in astigmatism treatment. So we lost 3 diopters of topographic astigmatism, but these 3 diopters of loss were really good and were really effective in the patient's life, because it was no longer an artificial situation where he put the 10 diopters of astigmatism on the phoropter, and he sees 0.7. Now he ended up with 6 diopters of cylinder, and the best corrected visual acuity jumped from 0.7 to 1.2. Okay. He felt improvement, but he, and honestly me, wanted more correction. I was going to prescribe not 6, of course, but I was going to give him in the neighborhood of 4 diopters of astigmatism, and hope that he will see 0.7 for the rest of his life, and that's it. But I wanted more. So we decided to tackle the corneal astigmatism with the other weapon, which is the excimer laser, or the laser vision correction. The first decision that had to be made: should we use, obviously, topography guided ablation, or shall we use wavefront optimized? Because this is a best corrected acuity of 1.2, and we do not want fancy ablation in this cornea that had a track record of having a mind of its own. So this cornea was absolutely fantastic, no rejection now, and had 10 diopters of cylinder. Again, when we did the intrastromal incisions, we did not correct much. So I didn't want to to give him a fancy topography guided ablation. If we just miss the registration with a few degrees, he can end up worse than his situation now. So the second decision: would we do a surface ablation, or would we do a LASIK? And if we're going to do a LASIK, would we do the mechanical microkeratome, or would you use a femtosecond laser on a patient who had previous femtosecond scars of complex scars, wide scars of mushroom penetrating keratoplasty? So these were our options. And I would have chosen topography guided ablation with a surface ablation. But this patient was due to travel in 10 days' time. He wanted a faster visual recovery than what was expected after surface ablation, as we all know. So I decided to go for a TCAT with a femto LASIK. Okay. So again, we do have the option, if we are using our machine, the FS machine, to do a nasal hinge flap, and you do have the option to do an oval flap as well. And these are the things that I used. And the patient, after we did a topography guided ablation, came from 5.7 diopters of astigmatism to 2.4 diopters of astigmatism. So this was a real improvement. Now we're talking. Now you have a patient who has a topography of 2.5 diopters of astigmatism, which will translate in a manifest refraction in the neighborhood of 1.75 diopters of astigmatism. So this is like a normal patient wearing normal glasses. 1 week post-LASIK, again, this was the topolizer, and the astigmatism showed 2.16, not even 2.4. So the manifest refraction would be much less than this. uncorrected visual acuity without any glasses whatsoever. It was 6.9. His refraction was 1.75 cylinder, and the best corrected visual acuity was 1.2. Patient was satisfied, and so was I. But he asked if I would recommend further corrective procedures. Now, in keratoplasty and keratoconus, the wise decision is knowing when to stop, in my opinion. So our option was to counsel the patient, advise him to wear his spectacle correction for the remaining cylinder and not to consider any more procedures, or to jump in and schedule the patient for an evaluation on his next annual vacation to prepare him for surface ablation to correct the residual cylinder. And honestly, this is what I told the patient. So, yeah. Run away.
The time is running away from you.
Okay, just one more minute. So just a quick resume of this case. Stigmatism was 8.5 diopters. It ended up after we did an arcuate incision without opening the incision to the surface to 6.7 diopters. We opened the incision to the surface, it was 5.6 diopters, and then we did him a LASIK and he ended up with 2 diopters. So this is what we did for this patient. So a quick overview. Classically, the post-PKP arcuate keratotomy was done freehand, and we had very, very poor actually nomograms like the Lindstrom nomogram and Hanna nomogram. I don't know if this is correct or not, but I've been told by one of the fellows of Lindstrom, he's an old man now, that he actually he wrote his nomogram after doing 9 patients. So this wasn't like something that stood the test of time or is evidence-based. Abby developed a nomogram for femtosecond AK, but again, this was for naturally occurring or native astigmatism. Humeric and Wu was the first one to develop FS AK nomograms for post-PKP astigmatism. This is the Hanna nomogram. McGee and Buzar has shown it was very, very easy for them to explain that the arcuate incision should follow the steep portion or the red portion of the topography. And the Toronto University nomogram is the most simple. They used pair arc incisions centered on the steep axis. And the Toronto formula used 60 degrees for 6 diopters, 70 degrees for 7 diopters, and so forth. The most recent nomogram was developed by Claire, and this is the publication. Again, it is a very good nomogram, but I still see that the Toronto formula is very handy in these patients. Thank you so much.
Thank you very much, Dr. Mohammed. It's nice talk, but there's not much time to discuss, I'm afraid. It's a pleasure to have Dr. Mohammed Imad Alilu. He's a consultant mid-care. He's going to talk about under and overcorrection, post-refractive surgery, how to handle this patient. It's Dr. Mohammed, it's all yours.
Dr. Osama, can you hear me?
Yeah, I can.
Dear friends and colleagues, good evening for all. I'm sure that after this heavy meal with Dr. Mohammed Husni and Dr. Sharif, a lot of cases, topography, I will try to make it simple and fast.
That's good.
My talk will be about undercorrection and overcorrection in post-laser refractive surgery. We will start as a refractive surgeon by the definition of success. What do you mean by success in the refractive surgery? It is defined as reaching the best possible visual performance without visual aid. But as we all know, visual performance has many parameters: visual acuity, contrast sensitivity, color vision, visual field, depth of perception. So it's a kind of multifactorial aspects which define the patient's satisfaction. Apart from the technical and ocular issues, there is also so many other issues like social, psychological, cultural, and the type of personality. So in conclusion, to determine whether it is overcorrection or undercorrection or when we need to intervene, it's the kind of multi-factorial decision which need to be taken. So sometimes we need to intervene even if the recorded vision is almost 20/20. So in order to move from this kind of general terminology to most specific scientific parameters, we went and sorry, I can't control the screen. So we went to the success parameters. I just want to share these simple definitions with my colleagues. The efficiency index, it is, I don't know, I'm seeing some chat pop-ups comes in the middle screen. Do you see something like that, Dr. Osama?
No?
Okay, so efficiency index, safety index, predictability of diabetic index. So those kind of parameters help us in defining the success of any procedure, whether that patient has benefit from this procedure or he had lost some of his vision and we need to intervene to restore the things back. So when we decide to intervene, we need first to know that why this is happening. Why is the source of the refractive problem, which comes for us? Sorry, I'm just seeing something coming on my screen. I need to fix it.
Yeah, for us it's fine, by the way.
Yeah. Now it's fine. So as we all know that the main source of in undercorrection or overcorrection is the refraction. The refraction measurement should have a gold standard, which is the manifest subjective refraction, but there is so many factors affecting this gold standard. Examiners, patient, lighting, room conditions, and it looks like also we were very successful in developing our tools. We have very excellent machine, lot of investigation and treatment machine, but still we cannot control the main source of error, which is the human aspect. So in the literature review, 80% agreement among multi-refractionists. They took around 40 refractionists and do and refraction a group of patients, and they found out that for a margin of 0.25, only 80% agreement with refraction, while for 95 within half diopter, the agreement jumped to 95%. So the human resource is one of the main factors. So we need to, as a preventive, in order not to get overcorrection or undercorrection, we need to be very careful in refracting our patient and have our standardized way of doing this. Psychological refraction is also another tool which helps us in detecting the accommodative or false myopes. And the gold standard is that the difference between the manifest refraction and the psychological refraction should be 0. So in case we have a higher difference, we need to keep in mind that there should be some lower predictability of the results. Flap and epithelium play an important role in deciding the final results, as we all know that cutting the flap and repositioning it will have its own effect in inducing some stigmatism. And also we all now more and more aware about the powerful epithelium and its ability to remodeling, plus the dry eye effect post-laser vision correction. I'm talking about this sort of error to know why we are having over and under correction. So excimer nomogram also play an important role. Some technical errors and failures, like the calibration of the machine, the special attentions to the sign of sufficient docking or microkeratoconus suction, the patient management and cooperation all play an important role in getting over and under correction. But now we need to go to the real life data. All these factors had resulted that we have a percentage of patients we need to intervene what is those percentage of patients? Sidleski et al. Has reported a prevalence of around 2.3 in a group of 2,800 eyes. Reinstein has reporting prevalence up to 4.4 in around 2,643. Those patients, 71% of the treatment retreatment were performed within the first year, with a mean waiting time of 10 to 11 months. So this is an important clinical point. We need to wait enough time, at least 6 months, and maybe up to 10 months, before making the decision of intervention. The retreatment done more for undercorrection than overcorrection. So we are, as a refractive surgeon, tend to undercorrect. And the retreatment, of course, was forced pseudocylinder in 86%. Now, when we decide to intervene and to do retreatment, we need to define or to classify the cases, whether it is an uncomplicated laser vision correction or it was a complicated laser vision correction which lead to this under or over correction. So we should start by getting the most information we can get. We have to go to do topography, tomography, apirometry, and even HD analyzer. Try to get the more information as possible from this patient, from this the cornea and the eye of this patient. And then we need to go and sit with the patient and have a very good informed consent. We have to explain the full information about his case and the risk which is related or connected with the retreatment. Then we tailor the treatment plan accordingly, according to the data we have and to the patient's what he is willing to accept and what he is refusing to do that. So if it is a simple regression, that will be the piece of pie, the easiest part. If it is regularly irregular cornea, if we end up with irregular cornea, we can consider in these cases topo-guided approach. And if it is irregular cornea, and this is most of the cases when we have a complicated laser vision correction or a severe complication, the approach here based on doing phototherapeutic keratectomy as a first step, and then reevaluate and decide what to do next. So
1 minute, by the way, Mohammed.
Sorry?
1 minute more.
Yes, I'm just wrapping. Treatment might take more than one steps in complicated cases. Just a quick reminder, LASIK, we have some options for retreatment. Either we can do a new flap or we can lift the old flap, and keeping in mind the higher incidence of epithelial ingrowth. PRK on top of LASIK flap, we need to be careful about the haze. And PRK, we can repeat the PRK with special attention to haze, or we can do LASIK also. The interesting thing is the retreatment options for SMILE. This includes circle, which turn that cap into a similar to LASIK flap. We can do thin flap LASIK on the top of SMILE cap if we have enough thickness. And we can do SMILE on top of SMILE, which is still an evolving approach. Thank you, Dr. Osama.
Thank you very much.
It was simple and fast.
Not fast, really. It's well meant. Anyway, so it's nice, and then hopefully we have more time, but at the finish, if we discuss anything. It's a pleasure to have Dr. Sandeep Mitra, as a consultant corneal refractive surgeon. He's going to talk about complication of failed procedure, which is always a challenge when you want to do a surgery, and then they have complication, and you have to deal with this complication. We can stop your share. That's good. So Dr. Sandeep, is all yours now. If you want to share your screen, please.
Yeah. So complication.
For the audience, you can write a question for audience. If you want to write any question, please put it in the question box so we can answer them. Yeah, go ahead. Sorry.
Yeah, thank you, Osama. Complications of failed refractive procedures is always a challenge. Let me start with the oldest technique, which has now become very popular, is the surface treatment, PRK. We know that haze is one of the complications.
Can you share your screen still, Sandeep? It's not shared.
Okay, just a moment. Yeah.
That's good. Thank you.
Okay, sorry. So one of the problems of refractive surgery which we see today is the superficial haze, which can be of different grade after PRK. Basically, there are two types. Type 1, which starts early, 3 months, before 3 months, and it disappears in a year time. And the other one is type 2, which starts late, and it takes up to 3 years to disappear. The problem is these haze gets aggravated with the UV light, which is more prevalent in this part of the world, which causes some sort of a myofibroblast proliferation. Topical steroid should be used for 3 months, and use of mitomycin 0.2 or 0.4% is advocated in these cases. But once you have an established haze, you can either do a transepithelial PTK with mitomycin, or you can do a lamellar keratectomy or a femtosecond ALK, and these haze can be treated very well. The next very common complication is Striae, which is seen in LASIK thin flap higher corrections, and this is because when the flap sits in higher corrected stromal bed, it tends to misalign very much, especially if it is a nasal flap. And the problem is if you miss the Striae in the early phase, then it becomes chronic, and then you have to deepithelize the surface and then treat the Striae. If you don't diagnose them early, then it becomes difficult to treat. So one of the things is you should put a drop of fluorescein as soon as you finish your LASIK treatment, and you can look for these Striae in the early phase. One of the problems which I have faced in relaxed smile procedure is keratoconus, although it's very rare. Now I have a patient, 27-year-old, perfectly normal keratometry, perfectly normal refractions and topography. There's no history of keratoconus in the family. His brother had a smile done and he was perfectly fine. His topography looked normal, and the thinnest cornea was 532 microns, and there was no inferior stiffening, and the K readings were very much normal. It was not steep cornea at all. So after all this, he underwent absolutely eventless smile procedure, and then there's something funny happened. After a week, his vision was not 6/6. His vision right eye was 6/6, but left eye was 6/7.5. And 12 months later, he presented to me with the blurring of vision, and he had developed astigmatic error. And then when we did the topography, we found this person is suffering from keratoconus. So definitely there was something we missed in this patient, and probably it's very important that in refractive surgery, when we are looking for keratoconus, we should use a multimodal approach, not just the history, the clinical examination. We should use topography, the Slem-Fuchs images, the posterior elevation, and today we can use the TBI. So once you have diagnosed its keratoconus, it's important that patient should be subjected to collagen cross-linking, and that's what we did for the left eye. And after 1 year, his cornea has not progressed. His right eye, of course, remains stable. So one of the challenges today is to find keratoconus early before you do refractive procedure. And I think the Randleman ectasia scoring is a very good guide towards that. This is another problem which we face, adenovirus infection after LASIK. The patient had a very uneventful LASIK 1 year back, and then came with adenovirus infection, and the vision had dropped. These patients, we have to treat them for at least 6 months to 1 year before attempting any procedure. The good thing is that the patient already had a regression. So by doing a PTK in this patient was not a difficult choice. We did a topography guided transepithelial PTK with mitomycin, and the patient did well. After 4 months, the patient recovered good vision. I'll not go into the treatment planning. Let's skip all that. The other issue which we see in smile patients is decentration. So when you are doing treatment with smile, it's very important that you dock properly and you don't decenter your treatment. But in case there is a decentration in smile, you should not remove the lenticule, and you just proceed with abolition of the surgery, and you can then replan the surgery either in form of LASIK or a PRK. However, if you just remove a lenticular decentered smile, it's a disaster, and the patient keeps having a lot of glare and halos, and the treatment is never good. Flap perforation is one of the rare complications in smile, but it can happen. Again, if it happens, it's better not to proceed, and it's better to stop the surgery and do a surface PRK topography guided, and these patients do well. Incision tears are also very common. This is very common because if you are trying to put an incision opening for lenticular removal less than 2.2, you can enlarge the flap while dissecting the lenticule. And again, this can induce astigmatism, and it's better to have a 2.8 or 3 millimeter opening while you're trying to remove the lenticule. Sometimes it also happens when the patient is trying to move the eye while you are trying to remove the lenticule, and it's worth that you stabilize the globe by counter traction so that there is no sudden movement of your instrument while you are inside the eye and you're trying to remove the lenticule. This is another complication which happens in smile, and this is a patient who had an uneventful smile procedure, and day one, the patient presented with poor vision because of island of lenticule was left, and you can see the anterior OCT, which is showing a lenticule which is left behind, and there's a irregular astigmatism. The best way is to mark the lenticule which has been left on a slit lamp, and then take the patient back to the operating lab table, use a slit to locate the lenticule, and then you can dissect it out and remove. If you do that early, the patient gets very good vision back. So this is a case. You can also do a negative staining. You can put a drop of Pred 4, and on the table you can pick up these lenticular fragments and you can remove them. Coming to LASIK flap injury. Now, this is one patient who had surgery done by me 10 years back, and he was doing well, 20/20 vision. Suddenly, he presented with a history of injury to his flap while he was cutting his mustache with his scissors. And he developed recurrent erosions and pain in this eye. Although his vision was good, but he was very, very symptomatic. So we did a PTK with mitomycin topography guided. Of course, the vision improved to 20/20, but he had to use glasses and he was asymptomatic. So this is another thing, the flap injuries can happen even years after LASIK surgery. This is another patient who presented to me from another place with vision was not bad, 6/9 after LASIK surgery, and she was complaining of some sort of a foreign body. And then when we examined the patient on slit lamp, we found a transparent piece of material left behind under the flap. So it's very important that once you do a LASIK, especially when you use microkeratome, that you drape the eyes well, and then sometimes the part of the drape is caught in your microkeratome and is deposited under the flap. So we looked at the flap, we just marked the transparent material on the slit lamp, and then we removed it after lifting the flap. The patient was asymptomatic and gained a vision of 6/6. DLK after smile is rare, but it can happen. This is another thing where you can see the spread of these white cells in the pocket where the lenticule has been emptied. And if you find that the treatment remains the same, you just go ahead and wash the interface with dexamethasone and put the patient on frequent steroids, both topical and systemic, depending upon the grade of DLK. Now, this is another patient. She was a 25-year-old Asian lady operated in a home country with LASIK. And she presented 15 days later with pain in her eyes. And she was advised to use Tobradex by her doctor without knowing exactly what has happened. And actually, she was poked by her son while she was holding her son with a nail. And surprisingly, the corneal scraping came as a fungal infection. And we had to start the patient on amphotericin because natamycin is not available with us. Ultimately, she had a perforation, which was then sealed with glue, with our cyanoacrylate glue. Luckily, she improved, her vision improved to 6/9 after 3 months of treatment. She has a central scarring, but her vision has improved. So injury after LASIK is possible, and it's very important that especially mothers with small kids, you should ask them to wear protective glasses when they are nursing their children. So refractive surgery is always a challenge because we are dealing with eyes which have perfect vision, and complications do occur. We cannot run away from them. It's better to manage them as early as possible. And if you are unable to do it, it's better to take an opinion from your neighbor. Thank you.
Thank you very much, Dr. Sandeep. That's perfect. Good.
Thank you, Dr.
timing also.
Sandeep. Okay, our next speaker will be Dr. Usama Ajledi. Dr. Usama Ajledi is a consultant of ophthalmology in Moorfield Eye Hospital, Dubai. He will talk about post-refractive corneal infection.
Okay. Good evening, everyone. Sorry, it's a long day for everyone, I think. Is it? Can you see it now? Screen.
Yes. Yeah.
So basically, I'm going to talk about post-refractive corneal keratitis. Keratitis after LASIK surgery is either could be infective, such as bacteria, fungal acanthamoeba, or it could be non-infective, as inflammatory with margin keratitis. It's more of anti-inflammatory, non-infective is more common really than the infective. I'm not sure it doesn't want to move.
It's working.
But it didn't move the slide. I'm not sure. It didn't move the 1 second. I just want to do something.
Okay.
But doesn't move the slide, isn't it? Slide is not moving. Is that correct?
Yes. Yeah.
No, sorry.
moving
Yeah,
now,
that's
yeah.
now. So for that. So post-LASIK infection is potentially devastating, but it's a rare complication. It is estimated like 1 in 1,000 or 5,000 procedure, you get risk of infection. Non-tuberculous mycobacteria, it was common at one stage, but now it's become much less. But MRSA become an increase, and there's different organisms that can cause infection post-LASIK. Staph aureus, one of them, Mycobacteria coloni, nocardia, but it's different spectrum of disease. It's very important really to know the epidemiology. In the survey 2001, Ascaris looking for post-LASIK bacterial keratitis. At that time, mycobacteria, almost 50% of the infection coming from mycobacteria. But since they started the 4th generation quinolone, 2004, really that it was a game change. So mycobacteria become rare 5%. But Staph aureus become more increased. 2008, the MRSA, it become over increased also, but still the mycobacteria and other become the same level. So epidemiology is very important to understand it, but use of 4th generation quinolone has helped a lot. Post-LASIK infective keratitis usually can be presented early, the first 2 days, but with atypical mycobacteria or fungal, it can be presented late, like 2 weeks to even 3 months. And usually patients have symptoms same like bacterial ulcer, reduced vision, pain. Although the pain post-LASIK is less because of cutting the flap, reducing the pain sensation. So the pain is not as the normal corneal ulcer, photophobia, discharge, redness, and lid swelling. Always when any case with suspicion infective keratitis post-LASIK, you need to do the culture and using broad spectrum. Shall we lifting a flap or not, or a antibiotic choice? That's the case by case, but usually need to understand that's very important, first of all, to understand risk factor and the prevention. I think the prevention is very important really, because patient coming for laser surgery, you want to improve their vision. The last things you want to have is to have infection for this patient, because that can cause a very serious problem to this patient, because any lose of vision, that's a problem. MRSA, as we say, is increased, and nowadays it's better to identify the carrier and to treat them before. Anyone had blepharitis, you need to treat that. And the surgery technique, really, you need to be very strict with sterilization technique, providine, iodine before. It's very important to have a good surgical drape, get this out, eyelashes out of the way. Always better to use 2 instruments for every instrument for 1 eye, so to prevent any cross infection. You don't want to have infection in both eyes if that happen. And very important, when you lift the flap, avoid any fluid go to the interface, and always using 4th generation quinolone. That's really is very helpful to prevent infection, especially the mycobacteria. When you had infections, it's always better to take a scraping to identify the organism and start intensive antibacterial treatment. Any case with suspicion of typical mycobacteria, which is usually patient will come after a few weeks from the laser and localize, infiltrate. Usually, this patient need to consider, when you do corneal scrape, consider as-fast staining and Lewis de Johnson media. And sometimes you need to ask the lab to keep this culture much longer than what we do before. Sometimes we need to keep it for 8 weeks to get the culture. Regarding lifting a flap or not, it's case by case. Usually, if it's periphery, you could do partial lifting, but if it's more in the center or near the hinge, you have to lift the flap completely. So the benefit of lifting the flap, first of all, you obtain the culture by debridement, cleaning the organism and inflammatory cell that help also. But also when you're lifting a flap, you could soak the bed with antibiotic that will have a strong intensive antibiotic dose for the infection. But lifting a flap, it will create striae, it will promote epithelial growth, and also painful for the patient. There's a problem with the LASIK itself. The flap is like not the normal corneal ulcers. That the flap is intact, the epithelium, so that's prevent good penetration of the antibiotic. It's recommended really sometimes to do debridement, to do like a small epithelium defect over the ulcer to allow the better penetration of the antibiotic. There's also risk of flap melting with the infection, and you may need to treat the patient for longer time for mycobacteria, and sometimes even you need to amputate the flap if someone not responding, especially for mycobacteria. Same things with any bacterial ulcer. If it's bacterial ulcer infection, you need to use fortified antibiotic, fortified like tobramycin, gentamicin, alternated with vancomycin. But non-tuberculous mycobacteria, you need to consider longer treatment. Amikacin, although they have poor penetration, but it's still the drug of choice for mycobacteria, other keratomileusis. Nowadays, the 4th generation quinolone, all of them is very good, effective, and really it helps us a lot to prevent it to happen from start, because really a nightmare to have mycobacteria infection. Tobramycin, ciprofloxacin, always consider oral keratomileusis systemic for this patient, but also with any corneal infection, especially after laser, you don't want to have any flap melting, so always start with doxycycline to prevent melting, because you don't want to change the refraction also. A steroid maybe worse the condition, and you need to identify organism. Once the patient improve, you start the steroid treatment. But if you had severe DLK, you may consider flap lift and wash as a treatment for both for the infection, but also for the inflammation. One study looked into the causes for infection, non-infective keratitis post-LASIK. Well, this is very huge study, really. It's 10,477 patients, so it's a huge. And looking for post-LASIK keratitis, 2.66% of people had keratitis. Good enough that non-infection cause is the main reason. So infection keratitis is 0.3%. So it's a rare compared with the non-infectious. Infectious case, adenovirus is common. But it's the non-adenovirus fungal bacteria parasitic is 30% of these cases, and the other causes herpes simplex keratitis. The non-infected cases, usually DLK, staph marginal herpes sensitivity 50%, or could be debris-related keratitis, that's also common. If you excluded adenovirus as etiology, really most of the common causes non-infectious one, and that's they don't have bad long-term side effect. This is one case, it's a really long time. This is 2003. This patient had, after 3 weeks from the LASIK, he had infiltrate. They did the hospital lift a flap. They did treat as DLK, they did the steroid, and did not respond, so they referred to us. We suspected typical mycobacteria. At that time, we're using chlorotrimicin, amikacin, or fluoxetine. We don't have the 4th generation at that time, by the way, in UK. So there's no improvement, it started to melt it more. So we lifted again and soaked it with ciprofloxacin. We created an epithelial defect to have better penetration of the antibiotic. And after 4 weeks from the culture, we had a growth that presumed nocardia, but later on, they confirmed the diagnosis Mycobacteria colony. And the patient really is slowly improving over the time. Over 9 months is regaining, there's a bit of haze, but the vision is still good, 6.75, which is good for this mycobacteria infection when you had, because sometimes it can be a very bad result. The other case, which patient who had 4 days after LASIK is complaining pain. You will examine this margin, infiltrate that. We lifted the flap temporarily, soaked with fluoxetine, tobramycin, vancomycin. we're creating epithelium defect, as I mentioned earlier, real epithelium defect that allow better penetration for this antibiotic. With intensive treatment, it's the patient improved. Patient had DLK. After some improvement, we start antibiotic, but we couldn't get any growth for the culture, but definitely look like bacterial and improvement antibiotic. The other case, like same things, painful, photophobia. This is 9 days after laser. It's localized suspicion. Is it mycobacteria or is it bacteria? So we did the same route, lift the flap, scrape it, and we use and initially intensive antibiotic, and there is no growth, but the patient is improving, so that's a good result. This patient really, I did it LASIK a year and a half ago. It's uncomplicated interlace LASIK, so we give the routine Bradford and Vigamox 4 times a day. The next day his vision is good, everything's fine, but 3 days later he complained of pain, photophobia. So the patient asked to come back to the clinic. So this is the 3 days, and we look carefully. She had a huge infiltrate in the flap edge and even outside the flap, so in both eyes, and diffuse, but the central look very clear. So at that time, shall I lift the flap, do corneal staining, scraping, or treat it as a bacteria or inflammatory keratitis? For me, because there's no much pain for this patient, it's the infiltrate really, it's looking extended outside the flap margin. It looked for me more inflammatory keratitis than infective. So increase the steroid to 2 hourly. I kept the Vigamox 4 times a day, but because it's just think about the blepharitis related, so I added physitalmic and add doxycycline for the melting and review next few days. And that's the patient has the infiltrate is start to improve it slowly over the about 2 weeks. Is everything clear up, and the patient is very happy, and the vision is maintained very well. So staph marginal hypersensitivity keratitis really it's a common really. I've seen it more common than infected one, and really you always they infiltrate in the periphery. It's typical to have some infiltrate outside the flap. Usually this is more typical of reactive one than infective, because infective will not go outside the flap without epithelium defect. Often consistent with the blepharitis, can be some epithelial defect, usually multiple and could be bilateral. A conclusion, really prevention is very important for these cases. You don't want to have infection if someone have coming for refractive surgery to improve the vision, because infection can affect the vision and they become unhappy patient. Any suspected keratitis post-LASIK should be investigated, and always consider infection and close monitor. If you have difficult case, refer to specialized center. Always consider a typical mycobacteria if the infection started after a week or 2. Staph coccal hypersensitivity is one of the commonest causes of keratitis after LASIK. It's a case-by-case management, so it always depends on the case. If not improve it, consider reculture, biopsy if necessary. A treatment post-LASIK non-tuberculous mycobacteria, it's challenging, may need flap amputation. Still amikacin, clarithromycin, and 4th generation, the best drug of choice. It can be potential site devastated, but really often will have a good outcome. But as I mentioned, this patient is different than patient who are coming with infective keratitis. This patient came for refractive surgery to improve the vision. So any infection, really, you need to be prompt and treated according. But really, the prevention is the cure, because I haven't seen much infection for a long time now. I think it's mainly how meticulous about the surgery and the medication used. That will be very helpful to prevent such devastating complication. And thank you very much.
Thank you, Dr. Osama, for the informative presentation. I don't know if we have time for discussion.
We can, I think we can, because we are the last session. So
we have one question here from the attendees regarding the time. If you have different time for PRK, different time of mitomycin application for the PRK. Dr. Osama?
Is it for me the question?
For all of the panelists.
Fair enough. Basically, mitomycin C really just is a bit different policy, different protocol. Really, if it's a very low refraction error, depends if it's Western person. I think if it's less than 3 diopter, less than 50 micro, I don't use mitomycin C. But any other people from Middle East, Africa, and Asia, I use mitomycin C regardless what's the refractive error really. So this is also the timing. I usually make it 20 seconds, but if it's a higher higher prescription, I increase it to 30 seconds. But one thing is different, really. I use the mitomycin C straight after I do the laser. And that's allowed the mitomycin to go deep penetrated. But if you do washing first, then you put the mitomycin C. Really, it will be different, completely different protocol.
Dr. Sandeep?
Yeah, I agree with Osama that mitomycin C, there is no definite protocol how to use it. And neither if there is any percentage, because it's very difficult. And most of the proponent of mitomycin is Dr. Majumdar from US. He is the one who uses lots of mitomycin. And if you see his articles which have been published, he has used various percentages. But probably it's better to use 0.02%, and 20 seconds is best. The problem is when you use mitomycin for a higher percentage and for a higher time, you might have a long healing epithelial defect for a very long period of time. And these patients, in fact, actually have more haze because of non-healing epithelium. So you'll be sitting with a PRK with non-healing epithelium, and they actually turn out to have haze. So you have to balance it out, when you are doing PRK. And I personally feel that anything more than -6, -7 diopter, if you cannot do LASIK or SMILE or PRK, it's better to do a phakic IOL rather than challenge yourself with higher corrections, because invariably they will have haze, especially in UAE, where the UV light is so strong. The main reason for haze is the metamorphosis of the proteoglycan and how the myofibroblast changes itself. So even if you give them mitomycin, they develop haze.
I just want here to add that I personally differentiate between whether it's I would say the first time intervention or a second time intervention.
The second time always mitomycin C.
Yes, but you have to use it longer actually.
Yeah.
If you have to do PRK over LASIK, you have to use it for a longer time. And I would take this opportunity to ask Dr. Sandeep here a question. You mentioned that the decentration flap, or sometimes you have to abort the case and do PRK. Do you use mitomycin routinely in these cases? And for how long? Because this cornea has been activated by a laser energy. As we all know that using the SMILE, using a femtosecond laser to separate the lenticule will activate the keratocytes. And you want to add on the top of it PRK or other intervention. You use mitomycin in this case, Dr. Sandeep?
So the first thing is that once you have cut a flap with femtosecond, it's better to wait. There is no urgency to immediately jump and do a procedure. The ideal situation should be that your lenticule should be 130, 140 microns deep. So when you are doing a PRK on the surface, you actually don't reach that depth. That's one thing. But yes, mitomycin C is required in these cases, depending upon the refractive error. And I don't think there is a big challenge there, because even if you do a femtosecond correction, the laser, although it damages the stromal fibers, the damage is much different than what you do with the excimer laser, which induces heat. So the effect of a femto laser on keratocytes is different compared to the effect of excimer laser on the keratocytes. So I think there is a difference, but I cannot say off record that there is a study to differentiate these two effects, one by excimer and one by femto, but they are not the same. So I don't think it matters. So if you're doing PRK over a femto laser, you should use a mitomycin C. And there's no risk of.
One more question came to my mind when you put these nice cases, actually, this decentered SMILE. When you reoperate, I do believe that there will be some edema in the tissue. So how long you are waiting before intervent and again, and would you correct the same amount of refractive error which originally calibrated, or you will correct the end up what you have end up with after this unsuccessful intervention?
So ideally, you should wait for 3 months, or at least 2 refractive errors which are a month apart where it has not changed. So that should be your criteria to proceed. Number one. Number two is I have only had one decentration which I treated with a LASIK, not PRK, because I had done an anti-micron flap and I could do the laser correction and there was no problem. But you're right, if there is an edema you suspect, and if you're doing an anterior OCT to document that there is a change in the thickness of the cornea, then probably it might. But I cannot say a correct answer here, because it has to be a study of 10, 15 or 20 cases, of decentered smile. And I don't have the record. I have only one case to comment on. So it's a very, very small.
Not only when decentered, when you have, for example, to abort the case and go and do thin LASIK flap on the top of smile, same consideration is applied, I think, because...
Yeah, it's true. You're right. So that's why you have to wait. I mean, what's the hurry? You can always tell the patient, look, the surgery didn't go well. Just wait enough for the refraction to stabilize. And I think we should wait as long as you can till the refraction stabilizes. So you should have at least 2 or 3 refractive follow-ups wherein the person's refraction doesn't change. And if you are suspecting that, okay, there is an edema on the stroma, measure the corneal thickness. You have anterior OCT, do a repeated measurement of corneal thickness and see what is happening. So you can document. So there's no need to hypothesize. You can always measure it and see how it looks.
Thank you for this, for your comment.
I think we need to wait for 2 months for the vision to be stable, and then we can do the enhancement either after film to LASIK, after smile. I don't know if
I agree. I fully agree with you, Dr. Sharif. You should wait. There should not be any hurry and jump and correct the patient.
Hi, Dr. Mohammed.
Hello, Dr. Osama.
Hello, Dr.
I hope you are doing well and you come to the end.
Yeah.
We already finished our
You have
session.
any question?
I want to come to say hello for everyone here in this session and to thank all of our speakers. And I would like to deliver my also thanks to the companies. They are sponsoring this conference, starting by Novartis, Spire and Allergan, Amico, Donatus, and FGC, and all others. I don't remember, Atlas. So I'd like to thank all our partners in this conference. I would like also to thank all our eminent speakers. They are sharing with us their experience and they are supporting in and handling all this and giving these talks during these 4 days. I'd like to thank you all, and many thanks also to the participants, and many, many thanks to my dear friends. They are sharing and preparing for this conference, the committees, scientific and organizing, and special thanks also to committees on cataract and refractive, vitreoretinal ROP, and also for glaucoma, Dr. Barrel, and for the oculoplasty. Thanks a lot. And if there is any success, it is because of you and all of our speakers and participants. They are attending this conference. And we are sorry and for any inconvenience. It happened during this conference. And we hope to see you, inshallah, in September with MIOM 16, 17, and 18. Thanks a lot and good night.
Thank you, Dr. Mohammed, for your recognized effort. Actually, you are the milestone in this event. And
thanks a lot.
Like to thank all the panelists.
Thank you, Dr. Mohammed, for your effort, and all Al-Qasimi Hospital team. Thank you so much.
Thanks, Dr. Sharif.
Thank you.
Okay.
Thank you, Dr.
Thank you, everyone.
Thank you. Bye-bye.
Thank you, everyone. And yeah, go ahead, Sandeep.
I thank you all.
Thank you very much, everyone. And good night, everyone. And thank you for the participants to stay late. And look forward to see you again soon.
Inshallah.
Inshallah.
Inshallah.